Welcome to the Paediatric IBD Digest, an educational podcast on paediatric inflammatory bowel disease, including Crohn's disease and ulcerative colitis. This podcast is designed for healthcare professionals, patients, and their families.
We, your hosts, Dr. Tracy Coelho and Dr. Chris Bakewell, both pediatric gastroenterologists, explore key topics with expert guests, offering insights, practical discussion, and the latest perspectives in the field.
But please note that all views expressed are for educational purposes only and don't replace professional medical advice. For personal medical concerns, we strongly encourage you to consult your healthcare provider.
Hi Chris, you know what? I'm now beginning to wonder that as gastroenterologists, we'll soon be sitting in dimly lit clinic rooms with our ultrasound machines, and endoscopies might just become a side hustle.
Well, hopefully not, but it does sound suspiciously like you're giving us a teaser. So let me guess, today must be about intestinal ultrasound.
Absolutely right, and we are treating our listeners to a two-part extravaganza, a full grand round experience with not one, not two, but 5 guests.
Right, you've officially gone mad. Even for us, 5 guests seems a bit too much. But, you know, I'll go with you. I assume this is going to be one of our masterclass episodes. You know, minimal banter, maximum brain power.
Exactly, very highbrow, and I can confidently say our guests will demystify those artistic grey, black and white blobs from the elusive universe of greyscale galaxies that we all politely nod at during the ultrasound scans.
Yeah, I'm pretty sure they're always going to stay black and white blobs for me.
Well, I must also admit, in the spirit of full transparency, 3 of the 5 guests have been ambushed in a highly opportunistic networking style from another study day. And to be honest, they never saw it coming.
Yeah, I've heard all about your networking. Should we say educationally borrowed? All right, no more dilly-dallying. Lights down, screens on, gel at the ready. Let's roll straight into our intestinal ultrasound masterclass.
So as we kick off with our masterclass on intestinal ultrasound, I am genuinely excited to be joined by our very first guest, Dr. Richard Jenkins. Richard is a pediatric radiologist at the Southampton General Hospital, known for being a very friendly face, which is exactly what you want when you walk into the radiology department with either a beautifully rational request or one of those, I swear something is wrong, but I can't tell you what. But either way, Richard is our man. Richard, welcome to the podcast. The floor is officially yours.
Hello, nice to see you all. Thanks very much for having me on.
Pleasure to have you, Richard. Thanks for coming. So let's start things off. And since today's topic is intestinal ultrasound, and our listeners are either going to be gastroenterologists or people interested in GI, maybe even some patients or family members, we thought we'd start by beginning right at the very start of the educational process of what intestinal ultrasound is. So if you wouldn't mind, would you be able to tell us what we mean when we say intestinal ultrasound, and how, for example, does that differ from when someone requests a general abdo ultrasound?
Sure. So intestinal ultrasound to me, or bowel ultrasound, is quite a specific subset of a broader topic, which is abdominal ultrasound. And it's a relatively younger field than general abdominal ultrasound, predominantly because the technological requirements for it are higher. So it's a targeted examination focusing on the bowel. In and around that, you'll also look at, there are secondary signs in the rest of the abdomen which relate to the intestine. Primarily it's the mesentery. That can be both the mesenteric fat, it can be the mesenteric vessels, and then wider, and this probably strays out of gastroenterology and into radiology. We're going to look at things like abdominal free fluid. I'm going to look at things like the liver and the spleen as they pertain to the bowel. For example, there are fairly characteristic liver appearances that go with bowel inflammation. And I'm going to look at those to maybe make me look a little harder at the bowel if I see it. And then the spleen, quite often in an unhappy bowel, in a case of IBD, I will more often than not see some splenomegaly. And again, I'm going to factor that in. Whereas I think probably in a gastroenterology context, it probably stops at that mesenteric fat and doesn't go wider. So if you go into a bit more detail, the focus of a general abdominal ultrasound is the solid organs. It's the liver, it's the spleen, it's the kidneys. And actually, traditionally, we often would have said it isn't very good for bowel. That's a little before my time, but that probably would have been said. Now you would probably say bowel is for a specialist opinion. So in the adult world, gastro sort of minded radiologists would do it, and the pediatric world, most pediatric radiologists will do it. And then now in the clinic, some gastroenterologists are doing it. The difference, I guess, as opposed to looking at those solid organs with intestinal ultrasound, you're looking at the bowel, you're looking at the bowel wall, you're looking at its thickness, you're looking at its vascularity, you're looking at its greyscale appearance, and you're looking at its morphology. The technique is a little bit more demanding on your kit. You can't do this really on older ultrasound machines well. You need high frequency probes, you need linear probes. In children, you're mostly going to be using something like a 615 probe, which is a very high frequency probe on the smaller children. And as they get into the teenage years, you're going to use a 2.9, and you're going to need a machine that can give you the resolution to look at bowel, which there are, things more than 10 years old actually probably aren't really up to it. I would say the technique is a little bit more demanding. The reason solid organs is so easy is they tend to be in a fixed anatomical location on the whole, and they respond very well to ultrasound as a technology. With bowel, the big thing that causes a problem is any gas it's basically a no-go for ultrasound. You get almost complete reflection of sound waves at a solid gas interface, and you're really stuck. But there are ways you can get around it, and I guess we'll talk about those later. The preparation is different for normal abdominal ultrasound, either fasting or full bladder. They're usually the only preparation you give. In intestinal ultrasound, I think there's actually not a consensus yet what the preparation is. I personally would always still want a full bladder to prepare for, because otherwise you won't see the rectum. To see the rectum with an empty bladder is incredibly difficult. And if you want to see the rectum, which you probably do, a full bladder is good. But I actually have been more convinced by intestinal ultrasound I've seen with oral contrast preparation as well, which just means something that's going to put fluid in the bowel, a bit like what you get for a magnetic resonance enterography. You can do it without, but if you can eliminate that gas problem by making sure most of the bowel of interest is fluid filled, that is worth doing. But then that crosses the downside of that crosses you into the specialist appointment territory as opposed to point of care clinic. It depends what you're doing it for. The outcomes are different as well. What you're actually looking to say here is some quite specific focused things as opposed to a general impression. You may or may not use a scoring system. What is the baseline, pre-treatment, and is treatment working? Whereas, in a more general abdominal ultrasound, often the questions are much wider and a bit more nebulous. I guess the last thing is, are you going to use it to look for complications? I think it is possible, but the skill level is higher. It's not undoable, anyone could learn. But if you need, say, and this is picking numbers out the air, if you needed 50 or 60 supervised cases to do, monitoring, I think you would need 100 or 200 to do genuine acute complications like fistula and abscess. Because that's actually it's a really hard thing. But yeah, I think in a nutshell, by rambling nutshell, that's probably what intestinal or bowel ultrasound is for me, in IBD at least.
So thanks, Richard. That was, really comprehensive, and I think brings up a lot of points that are important for later on when we go into some of the stuff that the adults are doing with intestinal ultrasound, so giving us a good grounding. Let's go back a step further into science classes, bit of physics. What is ultrasound? For people that have never come across this, because maybe you're a patient that's come to clinic, or maybe you're someone that never really learned, how does it differ from cross-sectional imaging like a CT scan or an MRI? What are we actually looking at here?
First principles, ultrasound is using sound waves, particularly high frequency sound waves, to give you a a version of a picture is what's happening. And all that you have is you have a little device that touches that be put on the skin. It's normally maybe, between 2 and 10 centimeters long. And that produces a sound wave, which goes into the abdomen in this case. And then that sound wave reflects back, similar to something like sonar. And it reflects back differently off different types of tissue. And it takes different amounts of time to reflect back from different, depths, how far away from you it is. And with that, you can then produce a picture of what's inside. I guess the key differences are what is the source of the imaging? CT, the sort of one of the traditional cross-sectional ways, uses what we call ionizing radiation. That's radiation that, generally speaking, comes with some associated risk. There's no radiation in ultrasound. MRI uses magnetic fields, so no radiation risk, but a much more complicated undertaking to perform. So I guess that leads into thinking, what do you need to do one of these? For ultrasound, it can be a clinic room, it can be a GP surgery even. You need very little in the case of, so there's no real need for general anesthetics or sedations, which in smaller children, for MRI, you almost certainly would have to do that. It can happen kind of anywhere, which means you can just go to a clinic and have it, as opposed to necessarily needing to be in a tertiary imaging department. The portability of it is, I guess, one of its strong things. Kind of the other sort of main benefit is it's a lot less scary. We have, in general, we have quite a big play therapy team, and we even hopefully will be getting a sort of what you call a play scanner, which is something the children can sit in that simulates an MRI. But the fact that we have all of these things probably gives you a feel how some children feel about an MRI. It's loud. It takes 45 minutes. The room feels very clinical, even in the best sort of set up children's environment where you have pictures on the wall and you have films playing. It's a big piece of medical technology that's intimidating. An ultrasound just really isn't. It looks like a computer, and you can set the environment. I quite commonly let the kids scan themselves for a little bit. You can have a much more relaxed environment. So in younger children, and children who have been very medicalized and therefore aren't particularly trusting of any time they step into a hospital setting, because, a lot of the times they've stepped in before, it's not been nice. Ultrasound is a lot easier to have them on side. And like I say, whenever sedating or giving general anesthetic for children, having ultrasound.
One thing I just thought of as you were speaking, so in lots of other areas of medicine, pediatrics especially, in A&E, people have started to use handheld devices. Now, I'm assuming you're going to tell us that there's significant limitations of using those for this specific modality, whether that's the probe or the processing.
Yeah, I don't think anything that's available on a sort of handheld footprint at the moment is sort of anywhere near reasonable treatment monitoring or, diagnostic intent in IBD. It'd be bowel ultrasound is probably one of the most technically demanding field, as far as of the equipment in ultrasound. So no, I don't think any of that kit is there yet.
Thanks, Richard. In your previous response, you spoke about the sound waves. Now, we do have a few guests lined up today who have made waves in the field of IUS in IBD, but I think it would be great to have your perspective. Now, intestinal ultrasound is increasingly used at the point of care in adult IBD units, with growing evidence supporting its value. However, its use in pediatrics is very limited. Now, do you think the outcomes or applications might differ if we extrapolate its use to pediatric patients?
I think a lot of the outcomes would be the same, and I think some outcomes would probably be better. And then I'll come in with my sort of caveats or slightly more problematic areas. Once you become familiar with scanning, children are easier to ultrasound than adults. They are smaller. They, in general, have a lot less intra-abdominal fat. You are scanning a structure that is maybe 3 or 4 centimeters below the surface, as opposed to 10 centimeters below the surface. That means you get a huge amount more detail, because you can use a higher frequency probe. So I think the quality of imaging can be better. In some other ways, they're slightly harder to scan, which is the environment has to be right. They might be non-compliant. They're often actually quite gassy, children, and that can be a problem. But I actually think the outcomes imaging-wise should be better. So as long as you have a reliable, robust framework of what you want to monitor and which parameters do contribute to sort of meaningful monitoring, which I think is still a bit of a work in progress, but I don't see why most of the ones from adults probably wouldn't apply, though there are some I'm less sure of. I think it could be better. So in a cohort where the majority of the disease is terminal ileal and colonic, I think in a child you should be able to get possibly even better monitoring, like, and treatment response monitoring output with children. However, in my experience, a not small number of children with Crohn's have other small bowel disease. I don't think it is probably up to monitoring someone for whom mid or proximal small bowel forms a significant amount of their disease burden, because even in a perfect circumstance, you are never sure you've seen all the small bowel. You just really aren't. The windows you get and the views you're taking, you might be sure you've seen a good proportion of it, but you've never seen it all. And then in the difficult cases, you've not seen most of it. So I think if we know someone has more complicated disease where they've got lots of small bowel disease, I think it's difficult. Also, I think if we know someone is prone to fistulating an abscess, I think there's probably still more of a role for, MRE or similar. One thing I'd say about that is I've noticed, and I don't think you've probably read more of it than me, but when I've read the papers on IUS, it often performs very, very well when the gold standard is colonoscopy. But that is measuring it against a standard that also doesn't see mid and proximal small bowel. If you find papers that measures it against MRE, it performs less well. And that's not been done as much because I guess neither is considered a gold standard, but actually the area that MRE outperforms colonoscopy is, mid and proximal small bowel disease. And I guess you would probably see similar if you benchmarked it against capsule. I don't know if anyone's done that. But my guess is it probably doesn't see the small bowel anywhere near as well as, capsule does. But I guess if you know at baseline that this is a predominantly TI or colonic disease, I think, yes, it will be able to produce similar or better because it's an easier patient to ultrasound.
Richard, that was a brilliant refresher. Thank you so much for the mini masterclass. I think we owe you coffee or at least a short holiday from our urgent but not really urgent requests. We now feel brave enough to call in our next lineup of guests and confidently pretend we know what we're talking about. But thank you so much and bye for now.
No, pleasure. Very welcome.
Thanks, Richard. So our next guest is Dr Krishna Shah, Senior Gastroenterology Registrar and IBD Research Fellow at the Royal London Hospital. She's IBUS certified, which of course we all know means it stands for International Bowel Ultrasound Society. Krishna is an IUS skilled gastroenterologist in adult medicine, and she uses the imaging technique she tells us every day, unlike the rest of us who are just trying to work out if we're holding the probe the right way up. Krishna, welcome to the podcast.
Thank you so much for having me here. I'm really excited to be part of this.
Thanks for joining.
So, Krishna, you're an expert. Every expert has a story. What would you say sparked your interest in intestinal ultrasound? Was it like a particular case, a mentor, or do you just like seeing the bowel sort of in real time?
Well, I'm not sure I would call myself an expert as yet. I'm sure there's always lots more to learn. In terms of interest, so I've always really enjoyed the practical side of medicine. So having a hands-on skill within IBD really appealed to me. I was doing my IBD research fellowship at the Royal London, and I spoke to my supervisors about how I could take it further. And one of them suggested intestinal ultrasound. And this was a couple of years ago, so it hadn't quite blown out the way it has over the last 2 years. And so I sort of explored the different avenues and thought, and there was someone doing intestinal ultrasound where I was working. And so I went along to have a look. I think it's always nice to try before you buy. And I really enjoyed it. And I think what really drew me in was the ability to get real-time point of care information. In the NHS, there are patients with symptoms who might wait weeks for cross-sectional imaging and thereafter a treatment decision. And with intestinal ultrasound, you can get point of care answers and imaging at the bedside and make a plan immediately. And I have to say that it's completely changed the landscape of outpatient and acute IBD. And I can't imagine going back to requesting an MRI scan and waiting weeks to get the result. So being part of that has been really exciting. And in the last couple of years, seeing the expansion and the interest of the field, which is growing rapidly now, has been really, really exciting. So I'm very happy that I chose this.
Wonderful. So Krishna, as you might remember, thanks to some strategic networking at that study day a couple of months ago, I managed to hijack you and a few other unsuspecting experts for this IUS series. Now, during your talk, if I remember, you covered some landmark studies on IUS in IBD. Could you walk us through the key studies that really showcase how IUS is making an impact as a point of care tool in IBD clinics?
Yeah, of course. So we can't really talk about the role of intestinal ultrasound without mentioning the METRIC study. And this is a UK-based study that came out of UCH Hospital. And it essentially compared IUS and MRI, so both performed by blinded radiologists, against a reference standard, which was a composite endpoint of different factors. And here intestinal ultrasound performed well, so it had a high sensitivity and specificity for detecting small bowel Crohn's disease. So it was about 92% for ultrasound and 97% from MRI. And then for ulcerative colitis, there have been a number of studies that have demonstrated the use of IUS. And I spoke about a meta-analysis by Malik et al. That pulls together a number of these studies. And this looked at patients who had an intestinal ultrasound within 1 to 3 weeks of having a colonoscopy and compared the findings. And again, ultrasound performed well. So it had a pooled sensitivity of about 89% and a specificity around 77%. So we definitely know that there is evidence for intestinal ultrasound. And then a key question was, does it then make an impact on our decision making or time to decision making? And we've got a really great study from the UK from my colleague Will Blad, who you're going to hear from soon. And during his time at UCH, he led a randomized controlled trial, and he looked at patients who were being seen in clinic and randomized them to either get standard of care investigations or to get a point of care intestinal ultrasound. Those results were then given to the clinician seeing them, and they would then make a plan. And his primary endpoint was looking at the time to decision and time to treatment initiation. And here, the median time to treatment decision was 0 days for patients who had a point of care ultrasound versus 58 days for patients who went down standard of care. And the median time to treatment initiation, and just to clarify, this was definitive treatment. So this was them starting a immunomodulator, a biologic, having surgery, or an endoscopic dilatation. That was 42 days in patients who had a point of care ultrasound versus 128 days for patients who went down standard of care. So he was really able to demonstrate that using intestinal ultrasound in clinic accelerated decision making and helped start effective treatment much earlier. And the other really key thing that he was able to show was that it was possible to do this within an NHS setting where the clinics are very busy. And I think that's really important when you think about how to implement IUS.
All sounds very promising, but you're forgetting the fact that we are lowly pediatric gastroenterologists with no prior ultrasound experience. So, Krishna, from your perspective as someone that's learnt the skill, how feasible do you think it is for someone to pick up a probe and start scanning? What's the process?
So I think it's really feasible, and that's exactly where I started out. So I had a little bit of experience with lung ultrasound, but never with abdominal ultrasound. So the current recognized training pathway, and the only recognized training pathway, is the International Bowel Ultrasound Society, which has a structured 3-module training program. And it's specifically designed for clinicians with no prior ultrasound experience. In some European countries, doing abdominal ultrasound is normal as part of the curriculum for gastroenterologists. So for someone who has experience in that, then there is an accelerated version. But the standard version is applicable to anyone. So it would be exactly the same for you. So you go through the module. In order to get accepted onto the program, which is currently oversubscribed and quite popular, you need to have access to an ultrasound machine at your unit, and you need to be able to demonstrate that you have the blessing from your supervisor or head of department to go off and train, because it does take time, and that you will have the ability to carry this on and carry it forward when you come back to your unit. And I think that's really important, because right now there is a limitation on how many training centers or certified people we have. And so we really want to make sure that if you're going through the training process, you can then become competent and then be able to train other people. So with the modules, the first one is a workshop. It's over a couple of days. You get hands-on training. You go through a lot of the theory. And then you go to module 2, which is a 4-week placement, which can be divided into 2 blocks of 2 weeks. And this is where you go to an IBA center and you get immersive high volume training. So you're just scanning lots and you are learning the fundamentals of scanning. And then the final part is module 3, which is currently being run at ECHO and DUW. It's a 1-day interactive course, and you have an exam at the end, and that sort of consolidates everything together. And in between, so once you have learned the framework of how to scan, then having access to a machine means that you can come back and scan at your unit. I think especially to start with, I would scan people for your own education. So people that are getting a endoscopy or an MRI scan, and just see how it correlates. So you're not using your scan to guide decision making. So you're purely doing it for your educational purpose. And then when you get the confidence to make decisions, in the images that you're seeing, then you can start doing this and relying on your images or your findings for decision making. So it's definitely possible. I think things that do help are having a mentor. So maybe having a radiologist or even an adult gastroenterologist as a mentor, so you can discuss images, discuss how to hold the probe or machines, and you can learn from each other and learn from each other's interesting images. But it's very feasible.
Okay, great. Thank you. So in the clinic then, we've learned how to do this. We're skilled, expert ultrasound, bowel ultrasound physicians. Let's talk about flares in disease. So ulcerative colitis versus Crohn's disease. The ultrasound findings would look quite different, right? Would you be able to paint our listeners a picture of what the typical features would be for a flare in each of those conditions?
Yeah, sure. So they may not look different, which is something that you learn through ultrasound. So we're always taught that ulcerative colitis is a mucosal disease. Actually, when you scan the patient, you see inflammation across all layers of the bowel. So you see transluminal inflammation. And I think there's lots of research coming out about that. So the general things that we look at in any patient when you start scanning them. So you always want to get an overview of what you're seeing. If you're looking at the colon, does it have haustrations? If you're looking at the ileum, is it moving well? Does it look dilated? Does it look narrow? So just you get an overall picture to see if something looks abnormal or normal. And then specifically, we're looking at bowel wall thickness. So this is the measurement from the lumen across the mucosa, submucosa, scleraris propria, and serosa. So you're looking at that measurement. And typically we say anything above 3 millimeters is thickened or abnormal. And I appreciate some of these values might be different with pediatrics. And I think there is lots of research coming out of the AMC in Amsterdam, for instance, to try and define what is normal and abnormal in the pediatric population. The other thing that you want to look at is the different layers of the bowel wall and see whether they're well defined. And usually when they're not very well defined, that's another measure of active inflammation. We're also looking at the vascularity, and we measure that using Doppler, and there's a scoring system to grade that. And then you're looking at other adjunctive features. So you're looking at the mesentery to see if it's brighter and whether there is mesenteric fat proliferation, which is another feature of active inflammation. You're looking for lymph nodes, and then any complications. So with ulcerative colitis, what you might see, especially with left-sided disease, often there's quite a stark transition point between abnormal and normal bowel. And that you can see quite well. You might not be able to see the rectum very well. I'm not sure how this differs in the pediatric population. And with Crohn's, then you are probably looking a little bit more for ileal inflammation if they've got ileocecal or limited ileal disease. And then especially if a patient's got a flare with Crohn's disease, you want to make sure they haven't developed a complication so that they don't have a new stricture or penetration or abscess. So these are probably the differences that you might see.
Great. And it sounds that obviously there's a lot you can look at, and you touched on it briefly there, but is there a standardized scoring system to put all of that together, or is it individual scoring systems based on the specific thing you're looking at?
So the main scoring system for Crohn's, but also is used for UC, is the IBA-SAS score, and it marks each of the things that I spoke about, and you get an overall score. And then for ulcerative colitis, you can also use the Milan score, and a value above 6.2 correlates with a Mayo endoscopic score of greater than 1. And I think those scores are very useful in research. However, in clinical practice, I think what really matters the most is providing clear descriptions, objective measurements, so that referring teams can interpret your images, and you can also assess for change between different scans and treatment response. So especially as ultrasound is not widely used across the UK as yet, I think that it's really good practice to put scores in there if you can. But the most important thing is making sure you've got an impression and something that a non-intestinal ultrasound performer can interpret.
Very elaborate, thank you. So Krishna, IUS has been getting a lot of attention for its convenience and speed, but no tool is perfect. Now, from your perspective, what are some of the limitations of IUS when compared to other imaging modalities like CT or MRI? Where does it shine and where does it fall short?
If we can start with where it shines, because I think it really shines. So there have been a number of different studies that have looked at patient satisfaction data. I think this is really important. And so there have been studies coming out of Morecambe Bay. There was a large study from the Royal London Hospital, and patients really like it. So patients prefer it to an MRI and a colonoscopy because of the lack of preparation. But also, I think what is really important is that it's non-invasive. You can do it multiple times. And also, patients have demonstrated that they're able to look at the images and get a better understanding of their disease and why treatments are recommended as such. And the patients are saying, which we probably have to verify with further research, that it's going to make them more likely to be compliant to their treatment. So I think that's a really important tool. In terms of limitations, so ultrasound may not necessarily always pick up mild disease. And I've definitely seen that for mild sort of Mayo 1 inflammation and ulcerative colitis, or that limited terminal ileal disease. Again, mild disease there. So I guess as well, you need to think about, is that what you're looking to find? And so I think whenever you see a new patient, at least in my practice, and a new diagnosis, they always get a mapping MRI to begin with, because the other limitation is proximal disease and proximal small bowel disease that may be difficult to pick up on intestinal ultrasound. And so it's really good to have a MRI baseline, if you can, an ultrasound, and you can see whether they correlate with each other. And if the ultrasound picks up everything you need to see, then going forward, you can just use ultrasound. Other limitations are body habitus. As we're seeing more patients with obesity, that can sometimes be tricky. Although I have to say that doesn't always mean that you won't get good views, because sometimes you can get really good views despite them having large body habitus. And then, as I mentioned before, the rectum can be difficult to see or make an assessment of. So those are the main areas. I would say mild disease, proximal disease, large body habitus, or limited proctitis.
Wonderful. Krishna, thank you so much for imparting all your wisdom and clearly hard-earned clinical experience, telling us a bit about ultrasound, and it's been a pleasure to have you on.
Thank you so much.
Thank you. So to continue on our IUS series, we will now be focusing on barriers to training and implementation. And I'm really thrilled to introduce our next guest, Dr. William Blad, a consultant in adult gastroenterology at the Royal London Hospital. He is not just an IBDologist, but also what I would like to call an IUSologist, a brand new specialty term I have just invented for this occasion. He is an IBUS certified trainer through the International Bowel Ultrasound Society and a passionate advocate for expanding intestinal ultrasound services across the UK. Will has also led one of the most widely quoted UK studies on IUS, so we are in safe hands. Will, welcome to the podcast.
Thank you very much, Tracy. Thank you very much for having me. Pleasure to be here.
Well, hi. Thanks for coming. For gastroenterologists, be that paediatric like us or adult like yourself, for trainees or consultants who are curious about learning intestinal ultrasound, what training opportunities are there at this moment in time? Thinking about structured courses, hands-on workshops, or even, something international that people can tap into.
So the first thing I would say is it's very much an area that we are trying to develop in the country with the BSG, the British Society of Gastroenterology, and also alongside the BUZGAR, which is the British Society of GI Radiology, looking at ways of trying to improve opportunities, because we recognise there are a few out there, but we need to kind of create more opportunities. I did an international course called IBUS, which is the International Bowel Ultrasound Group, which is a course that is available to anyone around the world. And it's a modular system to give you the foundation blocks to be able to perform intestinal ultrasound by yourself back in your department. It's a modular system where you do module 1. It's a simple kind of 2 or 3 day workshop. This is often done abroad, though we did the first one in London last summer, in 2024. It's a bit of hands-on training with models and with some patients, but also a lot of lecture-based theory and ultrasound theory as well, to get you kind of up to grips with how to use a machine, what we can see, what we can't see, and why we do ultrasound in inflammatory bowel disease. They then expect you to do a 4-week placement in IBUS certified training centres. That doesn't have to be in one go. It can be in 2 lots of 2 weeks. I did mine in Germany, and until recently that was only available mainly around Europe, but more and more places are opening up, and we have a couple of places in the UK who have had 1 or 2 trainees, and a few more opening up in the near future, or just opened, who will be accepting people going down the line. And then the third part of this system is a workshop, which has been previously at some of the big conferences, so ECHO, an adult IBD conference, and DDW, the big American gastro conference, where you do a workshop and a little exam at the end of that. So that's the kind of worldwide established training pathway that's available to anyone. Issues are trying to get onto it. It's very popular now, and they are accepting people. But I know people that have tried to get on it and haven't been able to. But the good news is we have some UK places that are taking part in that. So as I said, Module 1 has been done in the UK, and we will hope to do that again in the future. We at Barts Health offer Module 2, or have just opened up to offer Module 2, but as do a few other places around the UK. And we're slowly trying to get it in all parts of the UK. We're not quite there yet, but we're not just in London, which is good.
Thanks, Will. I hope I and Chris will be lucky someday to attend all these modules. So training is always a challenge in a busy NHS setting. So what do you see as the main barriers for gastroenterologists, whether pediatric or adult, who want to develop their skills in intestinal ultrasound? And realistically, how can we carve out time for this without disrupting routine service? For example, could things like training fellows or staff grades specialists help?
The barriers that I think are pretty clear, you've mentioned them, are time. Who has the time to sit down and learn a new skill that's never been learned previously by gastroenterologists? So there is a learning curve. That is, we are people who ultrasound a lot, or for most people, never. So you've got to learn how to use a machine, how you can kind of adapt the settings. So that's barrier one. But then also, once you learn the simples of using a machine, it's getting enough scans of patients to train you to be able to do it independently. And then the other, obviously, biggest barrier that I've alluded to in the last question is finding someone to train you. And even if you can get trained, someone to then support you going forward after that, because often you can do a module kind of IBUS. It gives you the foundation kind of building blocks, but you're probably not going to be 100% confident and competent to be doing everything independently. You'll be able to do certain scans, but you'll need support going forward over time. The time is the big issue. Trainees, I know in adult gastroenterology, struggle to get their endoscopy signed off. Maybe the same in pediatrics as well, but all of us are struggling to get all the skills we need in training. So to say, actually, I want, people who have an interest in IBD to also learn ultrasound, I think it's just unrealistic at this stage. And I think fellowships are clearly the way forward. And almost everyone I know that has trained has done it during a kind of a year out fellowship of some description. I mean, it's becoming very common for people wanting to do kind of a more advanced endoscopy doing fellowships. So I think it's where training's kind of heading anyway. And in the short term, there are definitely departments who are looking at creating, for us, I would love to create a specific IBD ultrasound fellow. Now, we have a couple of IBD fellows knocking about our hospital, and we're trying to offer them opportunities to learn ultrasound. But I think hopefully in the next year or two, we'll have specific fellow posts. And I think that's probably the simplest way to start training up the workforce. But we need to kind of hit that critical mass where there's enough people who can perform it and train in it. And I think we don't need to just look at gastroenterologists. We have to look to our radiology colleagues. I was trained by radiologists. I think it was very useful that I've been trained by radiologists and seeing gastroenterologists do it as well. But it's easier often to be trained by radiologists because they have dedicated lists where they sit down and do it in kind of more dedicated time if you can get your hands on that.
So let's say a gastroenterologist has completed their training in IUS. What happens next? What are the real-world hurdles to get a service up and running? Are we talking costs, equipment maintenance, clinic space, or something else entirely?
The first thing is, if you are going to join the IBUS course, one of the things they do stipulate is that you have access when you get back to an ultrasound machine. They ask what machine it is to make sure they think it's of good enough quality. They don't want people to be trained up and then not to be able to deliver that service down the line. They also kind of expect your head of department to write a letter to say this person is serious about doing this, X, Y, and Z, to try and mean that all training goes forward and then creates new trainers is the kind of idea. So you've got the skill set, you're ready to scan. Obviously, the most obvious thing is you need a machine. And there are inventive ways of doing this. In the long run, you need to get your own machine. You need to have access to it as and when you as a department want it. But that will cost you some money, tens of thousands of pounds to get a kind of a medium to high quality machine is what you need to do kind of good level bowel ultrasound. You need to have 2 probes, which is another £10,000 each. So these are things you do need a little bit of a cash investment to buy that machine. But just people I know who have found machines that they have used in their first process. A rheumatologist gave me an ultrasound machine that they've been doing point of care ultrasound for 15 years in clinic. So they are well ahead of us. They're getting the latest machines. They've got old machines they don't use as often. So they gave me a machine. I know a colleague that found a machine from the surgeons who weren't using it very often. And the radiology department, their machines are not being used 24/7. So their machines are around the hospitals. It's finding the right people to talk to who will let you start using it so you can build up that skill set. There's a small amount of running costs associated with having your own machine and thinking about we want to get images onto packs so we can view them in MDTs and look at them down the line. That costs a little bit of money as well. So those are little things to think about as well. It's not just the upfront cost. There are very small costs going forward. Finding somewhere to store it securely. Theft in UK hospitals is pretty high, so it needs to be secure, and you need a place to store it where you can get access to it when you want it, really. That's the kind of material costs, really. The other things that I've noticed in setting up a service that I found tricky is at first is being someone who performs this and everyone wanting you to do it. So it's setting up boundaries of how you run that service. What's your clinic template? Do you just plan people? They come in 3 months after starting a new biologic and have a scan, and you try and scan all new patients. Do you, like we've done, is set up a flare clinic, so new patients who are flaring, try and get them in, get a scan, do some bloods, do a CalPro, and then make a decision all in one kind of block. And we use that as a kind of teaching opportunity as well. So those clinics are set up to train people in ultrasound. And something that I've been going through recently is job planning. How do you plan this? We've all got job plans and they're all full. And now you say, I want to do ultrasound as well on top. So do you drop something? Where's that divide? Do you drop a bit of endoscopy? Do you do a different clinic? Do you do less clinic? Do you see fewer patients in clinic so you can do more ultrasound? So these are all things that have to be thought about and how you can kind of work things around to make this work. So it's not easy and there are a few barriers. Luckily, I've worked in places that have allowed us just to kind of work it out on the job, get it set up, get it going, and then we're kind of establishing these things and learning as we go.
Yeah, I mean, and the question you didn't answer there is, where do you store your machine? I've got visions of you taking it home with you at the end of the day, sort of bundling it into your car.
So we currently store it in a corridor in endoscopy, and it's padlocked to a wall. It's kind of a post, so it can go nowhere, along with a couple of bits.
Very NHS.
Yeah.
Perfect. This may be a boring question, so I'm going to ask it in as animated way as possible. Introducing new services, of course, ask questions about governance as well, and how you kind of manage that service for effectiveness, safety, making sure people are appropriately trained and such. So are there specific standards or checks in place that if you're thinking about setting this up that you need to make sure you're hitting, auditing?
Yeah, it's a question I'm regularly asked by radiologists especially. The first thing is the British Society of Radiology have produced a very clear guidance on this. I think along with the British Medical Society of Ultrasound or something along those lines. And they've produced a guideline on POCUS performed by non-radiology specialists. And we know the rheumatologists do it, A&E, acute medics, you've mentioned neonates. And so a lot of people are already doing this. But it's making sure that we are, as you say, trained and ready to do it. The main things they talk about is, one, thinking about the machine. They want you to have someone in charge. They want to lead in the department. They want you to understand the equipment. They want you to understand a bit about the physics of ultrasound and how it works. Have records of who uses it, who's been trained in it, and how were they trained. Think about data security. We link to packs. I think that's really important. So all the images are sent across to packs, and that's how they're stored. And I think more importantly are what training can one see as being sufficient to be able to start performing it. And I think that's really tricky, because if you do it in a place with radiologists who can also do it, they can almost give you the green light to say, you're ready. I feel like we've trained you up. You're good enough. Or with gastroenterologists who've been doing it for a long time. But for a lot of people who are setting up this service, they've kind of brought it to their hospital by themselves and no one else is doing it. And so they've they've been signed off normally on IBUS at the moment, but we hope that to change and we have other courses. And then they've audited their work. So for the first, let's say 6 months or 50 scans, they not changed what they would do based on those results. They still would get their colonoscopies or their MRIs, and then compare them to what they've done on their ultrasound and say, look, actually, yes, I'm coming. And I think it's quite good for the confidence to build yourself, to show, yes, I can do this. This works. And then I think going forward, once you set up that service, is making sure you do audit it. You keep an eye on it. What is it saving? What's it changing? Are you scanning loads of people, but then still booking everyone an MRI? Then it's probably not worth it. But if you reduce the amount of colonoscopy you do, or reduce the amount of MRI scanning you're doing, then obviously that could be a huge advantage. Or patients are getting onto treatment quicker. Maintaining CPD, so making sure you're keeping up to date with ultrasound, especially if you're doing it in a department where it's just you, or you're just kind of setting out. So making sure the latest changes you're kind of keeping up to date with. And the other thing they point out is something I'm a big believer in, is don't work in isolation. So try to collaborate. So even if you are the only person doing it, make sure you have contacts elsewhere that you can collaborate with and talk to. And they do say, if you can, though it's not an essential, work with imaging specialists where possible.
Yeah, thanks, Will. And that will be a concern, because one of the things that comes up when you think about developing skills in scanning is, well, gastroenterologists aren't radiologists, and while we think, we may learn how to measure bowel wall thickness, stranding, some of these measurements that are really specific to IBD. What if you have an incidental finding while you're scanning of something else and it's overlooked? How do you go about handling that?
Yeah, I think it's another really good question, something that has always worried me, and a little bit, especially when I started. There's a few things. So I think the first thing I always say, and I tell the patient, and I write it in my notes, that this is a focus ultrasound that I am doing to look at your bowel and your bowel only. I am not trained to look at anything else. And this is a test that I am using in conjunction with my blood tests, my calprotectins, my endoscopies, my other imaging, to help my clinical decision making, to make a plan today to move things forward. It doesn't replace me booking other tests. I still will get an MRI for every Crohn's patient when they're diagnosed. I will still, if they've got new symptoms that don't fit with my ultrasound, I will still get them other imaging modalities to have a look at that. You need to have a basic idea of what things you're going to see look like. The obvious ones are the things we always see are the bladder. We see gynecological kind of organs a little bit. And this is why I think, mentioning earlier, having an imaging specialist who you work with is really helpful. You don't have to be scanning with, but you've got one that you can take a picture, you record a cine loop, and you show it to them and say, Is this anything for me to worry about? It looked a bit odd. And most of the time they're like, yeah, that's fine, don't worry. But they can also be like, well, actually, no, yeah, let's just get a pelvic ultrasound in the department. I think it's probably fine.
Well, perfect. I think we have officially reached the end of our formal part of the IUS round. And now we enter the gut fire round, for which there is no peer review, no pressure, just pure instinct. So, Dr. Blad, the world's biggest IUS company has just decided to go full Hollywood, and they are launching a new James Bond styled ad campaign to promote their scanners. Naturally, with your impressive IUS record and landmark study, they have asked you to pick the perfect 007 inspired title for their blockbuster campaign. Now, I've got 3 choices. Which of them would you choose and why? So I've got 1, the IUS Royale, where the stakes are high, the gut walls are thick, and despite the severe inflammation, your mission is to keep a perfect poker face. 2, Probes Are Forever, a timeless classic featuring the world's most resilient ultrasound probes, slick scanning, and always getting a clear image no matter how gassy the situation. And 3, the GI Quantum of Solace, where our hero uses IUS to find inner peace and reduced inflammation. So what would you choose?
It's an easy one for me, in a way. I'm trying to remember what the title was for number 2. Probes are forever.
That's correct.
So the main reason in our department we have a machine with 4 probes, of which they've all got different names and they're all named after different. So there's the Will probe, which is my favourite probe, and other people's probes. And I think there is a bit of a nuance to probe decision and choice, and when you use different probes, and the right probe for the right patient, looking at the right thing is so important. And so for certain, the probe that I call the Will probe is not one that people generally have turned to in the past, and I think I've changed all of their minds, is what I'd like to think. So probes are forever, but the right probe is what we should use.
I wonder if you ever thought you'd get to a point in your life where you had a favourite probe.
Oh no, it's not how I set out on this career, but it's where I've ended up.
I hope the Will probe stays forever. Will, that was a great discussion. Thank you very much for joining.
Pleasure. Thank you very much for having me.
Pleasure. Thanks, Will.
Cheers. Bye.
Dear friends, thank you for joining. Hope you listen to this podcast forever. Take care.